Acute vulvitis. In the adult, gonorrheal vulvitis is found much less frequently than in the child or young woman. The squamous epithelium of the vulva is more resistant in the adult than the child, and the trauma of childbirth and marital relations make it more so. Symptoms. However, an acute vulvitis may occur and give very distressing symptoms. The chief of these are intense burning pain, worse on urination, a sense of fullness and weight, and extreme discomfort in the sitting posture or on walking. Examination of the vulva in these cases usually shows the entire vulva to be the seat of an acute inflammatory process. The labia may be much swollen and edematous, and their inner surfaces bathed in a copious purulent discharge. On separating the labia, excoriations of the mucosa may be found, and the intensely inflamed surface may bleed easily. Further examination of the vagina and cervix should be made with the precautions stated above, for occasionally the vulvitis may be primary, though more usually a urethritis and cervicitis also exist. Diagnosis. There are several conditions from which gonorrheal vulvitis must be differentiated. Simple vulvitis, due to lack of cleanliness. This is often found in obese women, especially in hot weather and where there is intertrigo. The absence of the gonococcus in the smear from such a case and its prompt reaction to treatment will easily differentiate this form. Diabetes often gives rise to a violent vulvitis due to the decomposition of the diabetic urine by the presence of the Torula Saccharomyces. The age of the patient and presence of sugar in the urine usually eliminate this form without difficulty. Vulvitis due to a vesicovaginal fistula can be differentiated by the history and the finding of the fistula. Vulvitis due to a discharge pouring down from a non-gonorrheal cervicitis or vaginitis may also be very puzzling until the discharge is traced back to its origin and a bacterial examination made. Vulvitis due to the excoriating effect of the discharge from a carcinoma of the cervix or vagina may also simulate acute gonorrhea in its intensity. Vulvitis complicating any of the exanthematous diseases can be differentiated by the history. Treatment. Primary gonorrheal vulvitis should be treated by rest in bed and absolute cleanliness. In the acute stage, the vulva should be irrigated every 2 or 3 hours if the discharge forms rapidly with a warm boracic acid solution or a bichloride of mercury, 1 to 6,000, or Lysol, 1/2 to 1%. The patient being in the dorsal position on a douche pan and the nurse gently separating the labia so that the irrigation may reach the internal surfaces of the labia and the vaginal and urethral orifices. After the irrigation has been given, a pledget of sterile cotton covered with sterile Vaseline should be placed lightly between the opposed infected surfaces to keep them apart. A Protergol ointment, 2%, can also be used with benefit. After 1 to 2 days, the irrigations may be given less often, and 3 times a day after an irrigation, the vulva may be painted thoroughly with Argyrol, 25%, or Protergol, 4%. If the vulvitis is secondary to urethritis, cervicitis, or vaginitis, the treatment must also include the special treatment of these parts. Oftentimes, when a vulvitis is secondary to a cervicitis, the cure of the vulvitis can be much hastened by sealing off the cervix from the vulva by a dry tampon of sterile cotton after the cervix has been duly treated. In these cases, it is very important that the patient be kept under constant care, as these tampons must never be left in long enough to dam back the discharge against the cervix and thus delay its healing.